So chapter 26, soft tissue injuries. Introduction. Soft tissue injuries are common. It can be as simple as a cut or scrape. It can be as serious as a life-threatening internal injury. Do not become distracted by dramatic open wounds. Do not neglect airway obstruction. So do not develop tunnel vision. There is always a patient attached to the limb. Focus on the entire patient. Soft tissue injuries of the body can be injured, soft tissues of the body can be injured through a variety of mechanisms. Blunt and penetrating trauma you're familiar with. Barotrauma is trauma from pressure changes inside the body. And then you have your burns. You have different types of burns. Soft tissue trauma is a common form of injury. Death is often related to hemorrhage or infection. And in the field setting, we focus on hemorrhage control first, then infection control second. Soft tissue injuries can often be prevented by simple protective actions. Now let's review the anatomy and physiology of the skin. The skin is the body's first line defense against external forces and infection. The skin is relatively tough, but still susceptible to injury. It can range from simple bruises and abrasion to serious lacerations and amputations. In all instances, the EMT must control bleeding, prevent further contamination to decrease the risk of infection, protect the wound from further damage, apply dressing and bandages to various parts of the patient's body. The skin varies in its thickness. It is thinner in the very young and very old, thinner on the eyelids, lips, and ears than on the scalp, back, soles of the feet. The skin is thin skin is more easily damaged than thick skin. The skin has two principal layers, the epidermis and the dermis. The epidermis is a tough external layer, so that's the top layer. The dermal layer, dermis, is the middle layer where we will have nerve endings, blood vessels, and hair follicles. And then below that, you have the subcutaneous layer. Skin covers all the external surfaces of the body. Bodily openings are lined with mucous membranes. And the purpose of these mucous membranes is to provide a barrier against bacterial invasion and secrete a watery substance that lubricates the openings. The skin has many functions. One, it keeps pathogens out, keeps fluid in, it helps to regulate the body's temperature, and it acts as a sense organ, so it picks up changes in the environment and relay that information to the brain. Any break in the skin will affect its function. So any break in the skin may allow bacteria to enter and increase the possibility of infection, fluid loss, loss of temperature control. Three types of soft tissue injuries you need to be familiar with as an EMT. Closed injuries, open injuries, and burns. Closed injuries, the damage is beneath the skin or mucous membrane, the surface is intact. Open injuries, break in the surface of the skin or mucous membrane, and it exposes deeper tissues to contamination. Burns, damage result from thermal heat, frictional heat, toxic chemicals, electricity, or nuclear radiation. Now that we have reviewed the anatomy and physiology, which you should be very, very familiar with at this point, let's look at the pathophysiology. What are we going to see if something is wrong? Now, pathophysiology. Cessation of bleeding is a primary concern. The next is wound healing, and this is a stage of inflammation. A new layer of cell is then moved into the damaged area. So when the skin is damaged and bleeding occur, the bleeding has to stop, right? So bleeding has to stop. Once it stops, then we have the inflammatory phase. And after the inflammatory phase, a new layer of skin is formed. Once a new layer of cells is formed. Once a new layer of cell is formed, then new blood vessels will be formed, and then we have collagen, which provides stability to the damaged tissue and joints in the wound borders. All right, now characteristics of closed injuries. History of blunt trauma, pain at the site of injury, swelling beneath the skin, and discoloration. A contusion is a bruise, but it can appear two ways. So if a patient has a contusion, it's a bruise, but it can appear two ways. They can have what is called an ecchymosis, or they can have a hematoma. Now, the difference is the ecchymosis is what Jamaicans call icky. So the same thing that we call icky is a ecchymosis. So what an ecchymosis is, small blood vessels are damaged below the skin, which results in bleeding, and it causes a blue and black discoloration. There is no swelling with an ecchymosis. The skin just look black and blue, right? That's an ecchymosis. With a hematoma, it is a large blood vessel that is bleeding under the skin, so you may see swelling with hematoma, right? And it can occur anywhere within the body. Anywhere it can occur. That's the difference. A crushing injury occurs when a significant amount of force is applied to the body. So if an area of the body is crushed for longer than 4 hours, the patient is at risk of developing crush syndrome. And I've already explained what crush syndrome is. The area where the crushing mechanism is, the tissues in that area break down over time and they become toxic components. If the crushing mechanism is released, these toxins can start circulating in the body, and it can result in the patient's pH becoming more acidic. It can result in kidney failure, and it can result in cardiac problems for the patient. When this occurs, it is referred to as crush syndrome. Now, compartment syndrome. Compartment syndrome is specific to fractures. And what compartment syndrome is, in layman terms, a steel fracture. So when a person or individual gets a fracture, and compartment syndrome will be common in the forearm and the legs. These are common places for compartment syndrome, right? Where there's limited space for bleeding to occur. So what compartment syndrome is, patient gets a fracture, but the fracture causes a tear in the membrane around the muscle, the fascia. Fascia that's around the muscle is not as elastic as other membranes in the body. So the membrane that is around the muscle, it is not elastic as the other membranes are. It doesn't stretch very well. So what can happen is bleeding can start to collect in that membrane that's around the muscle and the fracture, and then it starts to create compression on the injury. Right? So it starts to create tension or pressure on the fracture. It is a limb-threatening emergency. So if it's severe, the patient can lose function of the motor and sensory nerve, and blood flow can be cut off. It usually occurs 6 to 12 hours after a fracture. Right? So 6 to 12 hours after a fracture, the patient can develop compartment syndrome. So compartment syndrome results from the swelling that occurs whenever tissues are injured. Severe closed injuries can also damage internal organs. Assess all patients with closed injuries for more serious hidden injuries. Open injuries. In an open injury, the protective layer of the skin is damaged. The wound is contaminated and may become infected. There are 4 types. You have abrasions, which is a scrape. You have a laceration, which can be a clean cut, can be a jagged cut. You have an avulsion, which all that is keeping the area together is a piece of skin. It's kind of a partial amputation. Penetrating wounds. An abrasion is a wound of the superficial layer of the skin. So the top layer is affected, caused by friction when a body part rubs or scrapes across a rough or hard surface. A laceration is a jagged cut caused by a sharp object or blunt force that tears the tissue. It can be clean or smooth cut. If it's smooth and clean, it's an incision. So an incision is actually a laceration. And it can have various depth, right? So it can be a deep laceration, it can be a shallow laceration. An avulsion separates various layers of the soft tissue so that they become either completely detached or hang as a flap. Often there is significant bleeding. So the deeper it goes into the dermis is the higher the risk for severe blood loss. An amputation is an injury in which part of the body is completely severed. And we're talking about limbs, because if the head gone, it's an amputation. Sorry, it's a decapitation if the head is gone. A penetrating wound is an injury resulting from a piercing object. Can damage structures deep within the body. Stabbings and shootings often result in multiple penetrating injuries. Assess the patient carefully to identify all wounds. Pay close attention to the wounds that are in central locations: chest, abdomen, neck, head, groin area. Central location, pay close attention to those wounds. Ms. Carr, do you have a question? All right, I'm not hearing you. Moving on. Do you have a question, Mr. Morant?
Yes, sir. Whenever
Go ahead.
whenever suppose you deal with a patient that one of the intestine have pushed out of the belly. How would you proceed with that?
We're not at that point yet. Focus on what is being covered now. So we don't reach that injury yet. Focus on what I am covering now.
Right.
Good. And that's a big problem with this group, right? Learn to focus on what is being presented. You will cover all your concerns down the line. Assess the patient carefully to identify all wounds, count the number of penetrating injuries, determine the type of gun when possible, but do not delay transport. You may have to testify in court. Blast injuries, primary blast injury, damage caused by the blast wave and sudden pressure changes. Secondary blast injury, damage results from flying debris. Tertiary blast injury, the victim is thrown by the explosion, perhaps into an object. Now the patient assessment of closed and open injuries. More difficult to assess a closed injury than an open injury. You can see an open injury. Consider the possibility of a closed injury when you observe bruising, swelling, deformity, the patient reporting pain. Scene size up. Observe the scene for hazards to your crew, bystanders, and the patient. Consider whether or not you need additional resources. Take the most appropriate standard precautions. Be careful when you put your be careful where you put your hands, place your equipment, and how you package the patient. Focus on controlling bleeding. Bleeding control is going to be essential. Mechanism of injury, look for indicators of the MOI as you assess the scene. The MOI may provide information about potential safety threats. Evaluate the scene safety and consider additional resources. That's your scene size up. The next phase is your primary assessment. Identify live threats and transport priority. Form a general impression. Look for indicators of the patient's condition. Check for more serious hidden injuries. Check the patient's level of responsiveness. Assess airway and breathing. Provide high flow oxygen, whether it's going to be supplemental or positive pressure ventilation. Ensure that the patient has a clear and patent airway. Protect the patient from further spinal injury. Assess the patient for adequate breathing. Inspect and palpate the chest for decap BTLS. Circulation. Assess the patient's pulse rate and quality. Determine skin condition, color, and temperature. Check the cap refill time, especially in your pediatric population, not a must for adults. You may need to treat the patient for shock, and shock treatment is make sure the bleeding is under control, nothing by mouth, give O2 if it is required, keep the patient warm, and if protocol allows, fluid resuscitation, controlled fluid resuscitation. Don't want the patient blood looking like Kool-Aid. Transport decision. Immediately transport in these cases. Poor general impression, altered level of consciousness, dyspnea, abnormal vital signs, shock, or severe pain. Once we have completed the ABCs, we should know the patient's GCS. We should know if we need to do a rapid scan or focus, and we should know if it's a load and go or stay and play patient. If you have a critical trauma patient, time is important. Limit your on-scene time to less than 10 minutes. To be able to do that, you must have an effective team working with. Now, after the primary assessment, the next phase is history taking. Investigate the chief complaint, obtain a medical history, sample history. Using your OPQRST may provide some background on an isolated extremity injury. Try to use sample OPQRST and DCAP BTLS IC together. If the patient is unresponsive, attempt to obtain the history from other sources. Typical signs of an open injury: bleeding, breaks in the skin, shock, hemorrhage, disfigurement, or loss of body part. Secondary assessment. So after the history taking, next is secondary. After you evaluate ABCs and treat immediate life threats, a more detailed assessment should follow. Secondary assessment is a more systematic full body scan, typically occurs en route to the emergency department. Physical examination, you may be required to listen to breath sounds. If you have not already done that, you should be doing it again. Determine the respiratory rate, know the pattern and quality of respiratory effort, assess for asymmetric chest wall movement or paradoxical motion. Assess the neurologic system, assess musculoskeletal system with a detailed exam of the entire body, assess all anatomic regions. During the secondary assessment, we will be doing our recorded vitals, and we will repeat checks that we have already done in the primary. So we want pupil reaction, we want respiration, pulse oximetry, end-tidal CO2 if it's available, pulse rate, blood pressure, GMR. In the blood pressure for your trauma patients, well, for all patients, look at the pulse pressure. Somebody's mic is on. Whose mic is on? All right, continuing. So reassess the vital signs to identify how quickly the patient condition is changing. We need to identify trends. Is the patient trending up or trending down? Signs that indicate hypoperfusion and the need for rapid transport: tachycardia, tachypnea, low blood pressure. Weak pulse, cool, moist, and pale skin. Reassessment indicates how well the patient is tolerating the injury and the effectiveness of your interventions. Reassessment. Repeat the primary, assess the effectiveness of prior treatment, reassess vitals, and chief complaint. Recheck patient's intervention, reassess bandaging, identify and treat changes in the patient's condition. Intervention, assess and manage all threats to the patient's airway, breathing, and circulation. Give oxygen to patients with traumatic injuries that impact the airway or ventilation, or those with a potential for shock. Expose all wounds, control bleeding, be prepared to treat for shock. Flush small wounds. And note the slide says small wounds. So this is not something that is routinely done in the pre-hospital setting. If it's a small wound, it's fine. Be careful if it's a large wound, because if you flush a large wound, you might very well flush clots out of the area. There are some large wounds that can be grossly contaminated, where you definitely have to flush it with some saline, but it's not something that is routinely done for large wounds. Do not remove any material stuck in the wound. Splint extremities that are painful, swollen, or deformed. Communication and documentation. Description of the MOI should be included. The position in which you found the patient. Estimate the amount of blood loss. Location and description of any soft tissue injuries or other wounds. Size and depth of the injury. How you treated the injuries. Right now, emergency medical care for closed injuries. No special emergency care for small contusions. Extensive injuries could lead to hypovolemic shock. Closely watch any area of injury, no matter how minor. Treat closed soft tissue injury using Rice's mnemonic. Rest, ice compression, elevation, and splinting. Now, signs of developing shock that we need to be looking out for closed injuries: anxiety or agitation, changes in the patient mental status, increased heart rate, increased respiratory rate, diaphoresis, cool or clammy skin, decreased blood pressure, which is indicative of decompensating shock. Emergency medical care for open injuries. Before caring for the patient, follow standard precautions. If life-threatening bleeding is observed, assign a team member to apply direct pressure. Cover wounds of the chest, upper abdomen, and upper back with an occlusive dressing. Very important. An occlusive dressing is an airtight dressing. When we cover chest injuries and abdominal injuries, we will focus a little more on that. Control bleeding using direct, even pressure and elevation. Pressure dressings and splints. And you can turn a normal crepe bandage into a pressure bandage. I'll show you how to do that. Tourniquets can be the first choice or it can be the last choice. It depends on the patient's presentation and you will be guided by protocol. So if you're not properly trained to apply a tourniquet, don't apply it. And that's something that the government should be looking at. So not necessarily tourniquet application, but a campaign to teach the general population how to control bleeding. I think that would make a big difference in Jamaica. All open wounds are assumed to be contaminated and present a risk of infection. Control bleeding by splinting the extremity if there is no fracture. So you can actually use splints to create pressure on a dressing. All right, now abdominal wounds. An open wound in the abdominal cavity may expose internal organs. And this was a question that Mr. Morant was asking about. If the intestines are outside, what are you supposed to do? Right, so when the intestines are outside, it is referred to as an abdominal evisceration. Right, so that's the organs protruding through the wound. We cannot put the organs back inside of the patient. Right, so we can't put the intestine back inside. You cannot put that neatly inside the patient. They're going to need a surgeon to do that. So your goal is to ensure that the intestine doesn't dry out. And there are two things that we can do to prevent that. You can put on an airtight occlusive dressing and seal all four sides, or you can take a trauma dressing, wet it with some saline, put it over the intestine, then use a dry dressing to cover that. So that's your options, right? So As I say, eventually all your questions will be answered, but you need to focus on what is being presented, or else you're going to miss things that you need to understand. Right, so cover the wound with sterile gauze, secure the gauze with an occlusive dressing, it keeps the organs moist and warm. And as I said, if you don't have an occlusive dressing available, use a trauma dressing, wet it, put it over the intestine, then take a dry dressing and cover it. Right, take the dry dressing and put it over it. All right, now impaled objects. Remove an impaled object only when the object is in the cheek or mouth and obstructs the airway. So if the object is in the mouth and it's compromising the airway, has to come out. If the object is in the chest and it is in a position where you need to put your hands to do CPR, it has to come out. Otherwise, you leave it in. And if the object is impaled in the abdomen, there are no circumstances for you to remove that. It's outside the scope of practice. Now, neck injuries. Open neck injuries can be life-threatening. Open veins may suck in ear and cause cardiac arrest. That's in theory. So in theory, ear can be sucked into the veins and create an embolism. That's only in theory. There's no evidence to suggest that that has occurred in the field. So because of that theory, some companies will recommend the use of an occlusive dressing for the neck. Now, the most important thing with dealing with neck injuries is if you're going to control bleeding, you cannot bandage circumferentially. So you cannot go circumferentially. That will create pressure on both carotid arteries. So it's going to have the same effect as a rear naked choke, right? So it has to be done a specific way. We will cover that when we cover the skills. Small animal bites. A small animal's mouth is heavily contaminated with virulent bacteria. Wounds may require debridement, and debridement means they have to remove dead or necrotic tissue. May require antibiotics, tetanus prophylaxis, and surgical repair. Bites should be evaluated by a physician. A major concern is the spread of rabies. It is acute, potentially fatal viral infection of the central nervous system. Can affect all warm-blooded animals. It's transmitted through biting or licking an open wound, prevented only by a series of special vaccine injections. The human bite, so the human mouth is more contaminated than the dog mouth, unfortunately. The human mouth contains an exceptionally wide range of bacteria and viruses. Regard any human bite that has penetrated the skin as a very serious injury, right? And it can be deadly if it's a person that is on immunosuppressive therapy. Can result in serious spreading infection. Emergency treatment, apply dry, sterile dressing, promptly immobilize the area with a splint or bandage, provide transport to the ED. All right, so this is where we will stop. I'm not gonna go into burns right now. We will cover this portion of the chapter tomorrow. So this is where I will stop.